All right, so taking a look at chapter 30, this is talking about abdominal and genitourinary injuries. So the biggest thing we're going to talk about here is how to identify and also how to treat some of these potential injuries. So the abdomen is a major body cavity extending from the diaphragm down to the pelvis. We know that all of our organs here for digestive, urinary, and genitourinary systems are located here. So injuries could be coming from blunt trauma, penetrating trauma, or potentially both. So we're going to talk about some internal injuries as well as external. So just anatomy and physiology really quickly. We know the abdomen should be divided into 4 quadrants. So right upper, right lower, and left lower. And so we're looking to see where is their pain coming from, do we see any distension, bruising to those areas, and thinking about what organs could potentially have been injured. So hollow organs like the stomach, the intestines, the ureters, and the bladder, they usually contain something like digested food, urine, or bile. So if they are ruptured or lacerated, those contents can spill out into that peritoneal or abdominal cavities, and it can cause inflammatory reactions and infections like peritonitis there inside of that abdominal lining. So it can be very irritating. So there you're not just thinking about blood loss, but also potential for infection and those contents being present in the abdomen. Intestinal blood supply comes from the mesentery, and this connects the small intestine to the abdominal wall. So it's very vascular there, and patients with injuries here can bleed out into that peritoneal cavity, which could be life-threatening. So this picture here just kind of showing you the difference between hollow organs and then your solid organs. So the hollow organs over on the left-hand side, those are what we're concerned about potentially spilling their contents into the cavity. But then we also have our solid organs, which we are most concerned about the potential for blood loss. So any type of injury there can definitely be a life threat. So those solid organs, like we mentioned, the liver, the spleen, the pancreas, and the kidneys, they usually perform the chemical work of the body, like enzyme production, blood cleansing, and energy production. So because of this very rich blood supply here, the hemorrhage can be very severe. Injuries to the abdomen are considered either open or closed, as with anything else, and they can also involve hollow or solid organs. So closed abdominal injuries, we're looking at blunt trauma to the abdomen that does not break the skin. So this could be compression, like from a poorly placed lap belt in a vehicle or being run over by a vehicle. Those are just 2 examples. Could be deceleration, like a fast-moving vehicle strikes an immovable object, and we talked about how that transfer of energy happens. If you're traveling 60 miles per hour and you strike something that is not moving, then your body is now traveling 60 miles per hour, and then your organs are traveling 60 miles per hour until they come to a stop against a body part. So signs and symptoms of closed abdominal injuries, the pain can be very deceiving. It may be referred even over to another body location. So when with referred pain, we're thinking about pain is happening like in the shoulder or through to the back or in another area of the abdomen. And that's because all of that network of nerves and blood supply are interconnected. So sometimes that pain can be referred over, or it could be the entire abdomen. It's difficult to determine the location of the pain sometimes, so we're looking for guarding, which is stiffening of the abdominal muscles, and we want to try to get a good feel without guarding. So that's the purpose of starting away from the pain. So if they're having pain in one quadrant, we want to touch that area last in the hopes that they would not have those muscles as stiff after they've gotten used to you palpating the other areas and give you a better feel for what's really happening. Abdominal distension can happen from free fluid, blood, or organ contents spilling into the peritoneal cavity, so that's swelling there, but it's also very firm. Abdominal bruising and discoloration can happen. You might see abrasions initially, so thinking about like a seatbelt injury, you might see that initial small breaking to the skin or scraping of the skin, but then as you continue your transport, you might start to see discoloration or bruising happening as bleeding is beginning to accumulate underneath the injury site. So that might not be something you can see initially. So seatbelts, we know, are there to prevent injuries and save lives, but they can also cause blunt injuries to the abdominal organs, particularly if the seatbelt is worn improperly, like too high. It can also cause bladder injuries to pregnant patients. The way that the seatbelt should be worn properly is underneath the uterus, so across the hip bones in a pregnant patient, but that can potentially cause injury to the bladder. So this is incorrect versus correct positioning of an actual lap belt. Looking at open abdominal injuries, foreign objects enter into the abdomen and open that peritoneal cavity out to the outside. This could be a penetrating injury. So these open wounds can be very deceiving. So we want to maintain a high index of suspicion for things that could potentially be going on. The damage is going to depend on the velocity of the object. So if we're going back to thinking about the ballistic jelly that I showed you, and these are some examples. So low velocity, like a knife or another edged weapon. Medium velocity would be a small caliber handgun and shotgun. And then high velocity would be like a high powered rifle or handgun. So high and medium velocity injuries have those temporary wound channels that can cause that cavitation, which again we saw in the ballistic jelly previously. So just keeping that in mind about the shock wave that can also cause damage. And then the low velocity injuries, those internal injuries may not be so apparent. So injury at or below the xiphoid process may affect your thoracic and peritoneal cavity. So it could be affecting both the chest and the abdomen. The term evisceration is when the bowel protrudes from the peritoneum, and this can be very painful and also visually shocking for you as the provider. You should never push down or palpate on that abdomen if you've got actual organs that are protruding out. We should only perform a visual assessment. You don't want to put anything into that. Don't try to push it back in. Cut the clothing around the wound, but it's very important that you don't cut through any potential bullet or stab wound holes that are there in the clothing. Actually cut around them. And never pull on clothing that is stuck into the wound. So if it doesn't remove itself pretty easily, just leave it. Don't try to pry it out. Signs and symptoms from abdominal injuries are going to be like tachycardia, where the heart is trying to compensate for blood loss. Later signs would be evidence of shock, change in mental status, that drop in blood pressure, and potentially that continuation of the distended abdomen. Hollow organ injuries have a delayed signs and symptoms. They're spilling those contents into the abdomen, which can cause infection and pain, but generally this takes hours or days. Those highly toxic and acidic liquids in the stomach and the intestines leaking into the peritoneal cavity can be very irritating, but you might not see those signs and symptoms immediately, like while you're on scene right after this happened. Both blunt and penetrating trauma can cause hollow organ injuries. Blunt trauma generally causes them to pop or burst, whereas penetrating trauma causes direct injury like a laceration to the area, which is a little bit more clean cut. So injury is a little bit different. Air inside of that peritoneal cavity can cause pain, so severe infection and septic shock may develop. So something we want to stay alert there as well. Air can enter into any hole that you have in the body, but most susceptible when that hole is in the neck, the chest, and the abdomen. Looking at solid organ injuries, these can bleed significantly and cause rapid blood loss. This can be very hard to identify from physical exam as they're slowly oozing blood into the peritoneal cavity. That liver is going to be the largest organ, so very huge concern here. It's very vascular and can quickly lead to hypoperfusion or shock. It might be injured by a fractured lower right rib or from penetrating trauma. It can also cause bleeding from blunt trauma as well, like with a liver laceration can still occur even from blunt trauma. The spleen and the pancreas as well, very vascular and prone to heavy bleeding. We know that we can live without the spleen, but it is a blood storage area. So any injury there is going to cause a massive amount of blood loss into the abdominal cavity. And prior to it being able to be removed, it can cause a lot of damage. Looking at the diaphragm, when it is penetrated or ruptured, the loops of the bowel can actually move up into the chest cavity. That can cause a lot of difficulty breathing. So be very alert to that as well. If your patient is showing signs and symptoms of difficulty breathing from an abdominal injury, that this could be what has happened here. The kidneys can cause a lot of blood loss. You might see blood in the urine, which if you're not with the patient for a long period of time, you might not notice that. This would be something noticed at the hospital. There might be some actual pain to the back. You might be able to see some bruising to the back. And even though injuries to the front can cause this, you're looking for more blunt force trauma to the back or the posterior section to cause damage to the kidneys. So when we're doing our patient assessment and the patient has a potential or known abdominal injury, we want to look for the cause, and we're also trying to make sure that we are doing a thorough assessment. The pain may cause the patient to be overwhelmed by other things which are less life-threatening. So if you have a broken leg and you have an abdominal injury, what's going to be your main concern as the provider is going to be very distracting for you is that broken bone, but that might not be as life-threatening as this potential abdominal organ. So we don't want to get tunnel vision here. We want to make sure that we are doing our thorough assessment and looking for those signs of shock, and we know, hey, this shock might not be coming from this broken bone, might be coming from an internal injury. So we're looking to make sure the scene is safe, of course, calling any additional resources early on if needed, looking at our mechanism of injury, looking for any need for spinal precautions, that type of thing, and just having a very high index of suspicion for the types of injuries that could have been produced based off of this mechanism of injury. We're going to do our rapid scan looking for any outward injuries, but we're also keeping in mind that this could be something that has happened hours or days earlier. It is not uncommon for someone to get into a motor vehicle accident, feel fine at the scene, say, I don't need to be evaluated, and go home, and then start having signs and symptoms that are concerning, and then call 911. So you might not be able to see the vehicle or know what the mechanism of injury was, depending on what's going on. So we want to form our general impression, again, not being distracted by any type of gross looking hemorrhage or, broken bones, injuries that might not be life-threatening or that can be managed fairly quickly with hemorrhage control, but making sure we're doing that assessment to really look at what could be a potential life threat like internal bleeding or airway and breathing concerns. We want to make sure our airway is open, patent, that we've got good circulation. We're looking to see very early on that we need to treat for shock, so keeping the patient warm, keeping them as still and quiet as possible to help limit that potential for internal bleeding, administering oxygen if there is any difficulty breathing, and then controlling any outward bleeding. When we're making our transport decision, if they have a significant mechanism of injury and a known abdominal injury, you really want to try to take them to a trauma center where they can get the proper definitive care if they were going to be needing some type of surgery. Also pertinent to know about their medical history, so getting that sample, asking about any nausea, vomiting, diarrhea, asking about any appearance of bowel movements or urinary output if they have had the chance. Now, if this is a traumatic incident like a motor vehicle accident and it's just occurred, they might not know because it's just happened. But again, if this was a time that they've gone home or this has happened, hours before, then you would ask about that blood in the stool, blood in the urine, those types of things. Asking those questions about their medical history as well can tell you, do they take blood thinning medications? Do they have any, underlying medical conditions that could make this situation worse? We're going to do a thorough secondary assessment, especially if this is a critically injured patient. We don't want to delay transport before we start this, but we're doing our full physical exam, looking at the body for DCAT, BTLS, and very important that you expose the abdomen, that you're looking there, that you're palpating, that you're looking for distension, rigidity, rebound tenderness on palpation, that type of thing. We're palpating the quadrant furthest away from the pain, as we know, to hopefully prevent some of that guarding. We're going to do that full body assessment. Again, if you find a life threat, stop and treat it, but otherwise continue on. And we're looking for any type of bruising, swelling, or any other traumatic signs while we're looking at the body here. We're going to look at the vital signs. Abdominal emergencies can cause a rapid pulse and low blood pressure, especially if there is internal bleeding. So monitoring your vital signs can be that outward reflection of what's happening on the inside when you can't really see it and know what's going on. If the mechanism of injury suggests an isolated injury to the abdomen, then you would focus your physical exam there just as you would with any isolated injury, but otherwise it will be the full body secondary assessment looking for DCAT, BTLS at all parts of the body. When we're doing our reassessment, we're going to repeat the primary assessment and reassess our vital signs. Remember, 5 minutes if the patient is critical or unstable, and 15 minutes if they're stable or not critical. As far as interventions, aggressive treatment for shock that we've mentioned, keeping the patient still, quiet, oxygen if needed, and temperature control is huge. And then we do want to cover any wounds, which we're going to take a look at here in just a minute about how we can cover and address those wounds. If it's bleeding, if it is a full evisceration, what do we need to do? And we need to give relevant information to the receiving hospital and describe the scene, describe the vehicle, describe how the patient was injured, describe the wounds that you see. Give them that information so that they're prepared for your arrival. So if this is a closed abdominal injury, the biggest concern is not really knowing the extent of what's happening here, and also your blood loss that you really can't account for because you can't see how much blood is being lost, and a significant amount of blood can be lost in a short period of time inside of the abdominal cavity. So unless the patient needs to be lying supine on a backboard due to spinal injury, then we do want to try to keep them in a position of comfort, keeping them still and quiet, oxygen if needed, and temperature management, again, helping to treat for shock. Patients with blunt abdominal injuries, they can be log rolled to a supine position on a backboard. That doesn't interfere with your log rolling process like an extremity injury would if they do need that backboard. Looking at open abdominal injuries, patients with penetrating injuries, we want to maintain a high index of suspicion for unseen blood loss. We're going to look at the patient's back and sides for any potential exit wounds or additional wounds here. Apply dry sterile dressings to all open wounds. And if the penetrating object is still in place, then we're going to stabilize it. All right, very important that we stabilize that object. The only 2 times that we would remove the penetrating object is if it is interfering with CPR or interfering with airway management. So in the abdomen, we don't really have either of those concerns. So this should be staying in place and stabilized as much as possible so that we don't cause any additional injury going with removing that. If it is an evisceration, all right, so you've got organs protruding out, which is what you see here in this picture, it's going to be very distracting to you. It's very important that you work quickly. Again, do not push any of those organs back in. You might have some fat protruding, like a yellow subcutaneous layer out through the wound as well. We do not want to try to replace the protruding organ. You need to keep it moist and warm. So as for everything else, you put on a dry sterile dressing, but for this, you want to use moist sterile dressing, and you want to try to secure it as much as you can. So my advice to you would be to use something that is not going to stick, so moist. So if it's a large area that needs to be covered, then you could use like your sterile gauze. Don't use towels or anything like that. Use a lot of sterile gauze, like abdominal pads, something that's not going to disintegrate. We don't want those fibers in the abdomen. And you can wet those with your sterile water and then put them over the abdomen. And then if you need to seal that off, if you have a large amount of plastic like saran wrap on your ambulance, then you could do that. If it's a smaller wound, and then you could use the same process that we would use for a chest injury, which would be that Vaseline gauze and then the foil or plastic packet underneath that to create an actual occlusive dressing to the area. So it really just depends on the size of the wound and what all is happening with it. Looking at the anatomy of the genitourinary system, it controls the reproductive functions and waste discharge. So genitourinary organs are located inside of the abdomen, and that includes the kidneys, the ureters, the bladder, the urethra. The male genitalia lie outside of the pelvic cavity, and the female lie inside of the pelvic cavity. And so we've seen these images before as far as how all of these work with the urinary system of the male, of the female. And so we're familiar with the organs and the potential for injury that could be there, both internal and external. So with kidney injuries, these are not unusual and rarely occur in isolation, meaning that there's generally additional injuries to the body. It's not usually isolated specifically to the kidneys. This can happen from a forceful blow or a penetrating injury. We want to suspect kidney damage if the patient has evidence of any of the following. So abrasion, laceration, or bruising, contusion to the flank, which is that lower back area. Penetrating wound in the region of the flank or the upper abdomen. Fractures on either side of the lower rib cage or of the lower thoracic and upper lumbar vertebrae, or a hematoma in the flank region. Looking at urinary bladder injuries, this could result in rupture, like we said, where the urine would spill out into the surrounding tissues, causing some type of irritation and potentially infection to the area. Blunt injuries to the lower abdomen or the pelvis could cause rupture to that urinary bladder. It could also be deceleration that could shear the urethra for a male patient. And in later trimesters of pregnancy, then bladder injuries are going to increase because we know the pressure on those organs is already increased. This is just one picture of how a potential bone fragment from a pelvic fracture could cause a rupture of the bladder. External male genitalia injuries like soft tissue wounds. So these are very painful and obviously of great concern for the patient, but are rarely life-threatening. So this should not be given priority over more severe wounds unless there is severe bleeding, like with the potential amputation of the genitalia shaft. With female genitalia injuries, usually these are going to be internal, so we're looking at the uterus, ovaries, fallopian tubes. These are rarely damaged. They do have some type of protection unless the patient is pregnant, and then obviously that becomes the center of gravity, and it's out of that protective cavity of the pelvis, and it can be more serious, and we also have to take into consideration the baby as well. The external female genitalia, like the vulva, the clitoris, major and minor labia, these have a very rich nerve supply, making these injuries very painful, but again, not really life-threatening. We do want to consider sexual assault and the potential for pregnancy. If there is any external bleeding, then a sterile, absorbent, sanitary pad can be applied to the labia, but we never want to insert anything into the vagina regardless of the amount of blood loss. So this could be a very embarrassing situation for the patient, so we want to maintain a professional presence, provide privacy, have an EMT of the same gender performing the assessment whenever possible. You can also look for blood on the patient's undergarments, and again, if this is a situation where you're suspecting sexual assault, we don't want to let the patient urinate, defecate, wash, change clothes, anything like that, because we don't want to lose that potential evidence. So we want to look at the scene again, making sure that it's safe, looking for indicators of the mechanism of injury. The patient may want to avoid discussion while they're undergoing physical exam, so try to respect that and respect their privacy and understand that this is kind of embarrassing for them no matter what the situation. Quickly scan the patient to identify any life threats. Do not avoid this area in the rapid scan. So very important that we're looking here for injuries if we have reason to suspect that. Form our general impression. Ensure they have a clear and patent airway, of course. We're looking at circulation, making sure that rate, rhythm, and quality of the pulse is good, identifying any blood loss, and if we need to address, external blood loss at this time, we definitely could. Still asking those same questions about the injury, asking about any nausea, vomiting, diarrhea, blood in the urine, or emesis like vomit, abnormal bowel and bladder habits, that type of thing. Asking questions about their last intake of food and fluids, especially if you're concerned that this is a urinary issue and there may have been, some potential for dehydration and that type of thing. Genitourinary system injuries, as we said, can be awkward to assess and also awkward for you to treat, so privacy is a genuine concern. Trying to make sure that there's limited amount of people around while you're handling the situation. Trying to move out of the public and into the private area of the ambulance is very important. Looking for DCAP BTLS and identifying wounds, controlling bleeding. Start with that full body scan if there's significant trauma. Reassessing the vital signs, looking for tachycardia, drop in blood pressure, cool, moist, pale skin. These things that are going to let us know that the patient may be going into shock. Again, like we said, we're just reassessing our interventions, and we're reassessing every 5 minutes if the patient is unstable, every 15 if they are stable. And we're going to communicate all concerns to the hospital and let them know, and then we're going to document this thoroughly. If the patient has a kidney injury, it may not be obvious, and again, until we see signs of shock or blood in the urine. So we're going to transport promptly to an appropriate facility and continuing monitoring vital signs. If it is a urinary bladder injury, we want to suspect this if we see blood at the urethral opening, signs of trauma to the lower abdomen, the pelvis, the perineum. Again, this could be caused from penetrating or blunt force trauma. It could be related to a sexual assault. Just depends on the situation. In the presence of shock or suspected shock, here again, transporting promptly, treating for shock. If it is the external male genitalia, calming the patient down is going to be of the highest priority. Use sterile, moist compresses to cover the areas of stripped skin. Never move or manipulate foreign objects that may be in the urethra. So you don't really need to stabilize that if they are stabilized on their own, but you don't want to pull it out or try to manipulate it at all. If there's any avulsion to the area, you do want to put it in a bag, try to put it on an ice pack or cool pack, and try to take it to the hospital with you for potential reattachment. If it is full amputation of the penile shaft, then managing blood loss is the top priority. Connective tissue surrounding it could be damaged, it could be fractured or angled, so this could be associated with very intense pain, a lot of blood loss, and a lot of fear from the patient. So again, it really just depends on the situation. If we're talking about laceration of the head of the penis, this could be associated with heavy bleeding as well, so applying pressure with a sterile dressing. If it's skin or shaft of the foreskin caught in the zipper, if it's a small piece of the zipper, you could try to unzip it, but if it is a long segment of the zipper that's involved, cut the zipper out of the pants with heavy scissors and leave it in place and allow them to remove this at the hospital. Urethral injuries are not uncommon for the male patient. So straddle injuries, pelvic fractures, penetrating wounds of the perineum, all of these are potential. So we do want to ask if the patient can urinate, and if they can, if there is any blood in the urine, if there is any foreign bodies stuck in the urethra, they might need to be surgically removed. Avulsion of the skin of the scrotum may damage the scrotal content, so we do want to try to preserve those avulsed skin pieces as well, wrapping them in sterile moist compresses and placing them on a cool pack or ice to take them to the hospital. Direct blows to the scrotum can result in rupture of a testicle or accumulation of blood around the testes, so we can apply ice to the scrotal area to help relieve some of the pain, and consider ALS management for pain as well. For the female genitalia, treat any lacerations and avulsions with moist sterile compresses. You can use local pressure to help control the bleeding. We don't want to put anything into the vagina, but we can put something on the outside to help control the bleeding. If there's any foreign bodies, again, leave them in place, stabilize them. These injuries are painful and embarrassing, but not usually life-threatening, but hospital evaluation is required. How urgent this is will depend on if there's any bleeding, how much is it, is the patient have the potential for shock, that type of thing. And then rectal bleeding could be caused by sexual assault, rectal foreign bodies, hemorrhoids, colitis, ulcers, or hemorrhoid surgery. So you're just trying to look at the potential cause. This is rarely life-threatening, so we do want to ask those questions about, how long has this been going on? Is it coming from nature of illness, or is it coming from a traumatic incident? And then asking those appropriate questions for that. Looking at sexual assault, this is unfortunately common. So victims are generally women, but can sometimes be men and children. It's often very little that you can do beyond providing compassion and transport. But if the patient has sustained multi-system trauma, then we do want to treat for shock and transport them to a trauma center. So do not examine the genitalia unless there's obvious bleeding that requires application of a dressing. Follow your appropriate procedures and protocols. Shield the patient from curious onlookers, again, maintaining as much privacy as possible. And then document their history, assessment, treatment, and response to that treatment. Follow your crime scene policy, again, advising them not to wash, bathe, shower, douche, urinate, or defecate until after examination. And we want to keep their clothing intact, handling them as little as possible. But if they have, taking them off already, transporting them in a paper bag, not plastic, to help preserve evidence. So that's it for this chapter, and I will catch you guys in the next video.